Welcome to our second meeting in trying to do our best to contain healthcare costs in the great state of Oregon. I'm trying to read this, but I have forgotten my glasses, and I can see everybody there, but I'm struggling here. So I do want to make a couple of introductions to a couple folks who are going to serve as project managers for this effort. And they are in the audience. Sarah Bartleman. Sarah, you are here. Can you raise your hand? Thank you. Welcome, and thank you again for your help. And also Tara Chetok. Have I got that right, Tara? Yes? Thank you very much for your great efforts. Thank you. Welcome. We also need to approve the minutes. Has everybody had a chance to review the minutes, and can we get a motion to approve those, please?
So moved.
So moved. Do we have a second?
Second.
Second. All in favor say aye.
Aye.
Aye. Good. Okay. Jeremy, I can't read the second point.
That's fine, I can take it. I think it says Jeremy, yes.
Jeremy, okay, that's what I thought it said.
So we'll use this agenda item each month to just kind of any things that we need to bring back to the group or any updates. So just a couple quick updates for folks. First of all, we sent around a report that came out last week by Manat Health and Robert Wood Johnson. It's a project that started almost a year ago, actually before legislation had even started to work its way through. The legislature, Robert Wood Johnson, and a well-known national foundation has been tracking what states are doing in partnership with Manat. Manat did a project to interview a number of folks in Oregon, including some folks on this committee, as well as some other stakeholders, to really talk about kind of what folks saw as the value proposition and challenges of this. So the framework within that doesn't exactly follow the same agenda flow that we have, but I think some real good summary of feedback, early feedback from stakeholders, as well as some good just things to think about as we're going through this over the next year. So hopefully you'll find that to be a good resource. We will talk a little bit towards the end, a little bit more about stakeholder input, but wanted to just let you know we are continuing to think about ways to engage a broader group of folks. So we'll have a couple minutes towards the end to talk about that, but then plan to give a longer update in January. You can see we've moved to a larger room, and we will try to be in this room or a room about this size whenever we can. I think there's a couple meetings we couldn't find a larger room, but as you can see, we've got a lot of folks, and want to make sure that folks were comfortable. So we're trying to be in this room whenever we can. We're also expecting public comment probably will increase as we go throughout this process. So for folks that are looking to provide public comment, please make sure you sign up and know that we'll be limiting folks to about 2 minutes. And then finally, I'll just say CMS this last week put out new national healthcare spending per capita nationally. Healthcare grew about 4%. We don't have new state data yet from the national CMS data, but just thought folks might be interested in that.
What are the years on that, Jeremy?
That's 2018.
2018.
Sir, Zachary, anything I missed? Oh, I want one last thing actually. There was a few data requests at the last meeting. In particular, looking at, we had shown with the all payer all claims database that there was a 6.5% spend rate in Oregon from 2013 through 2017 or 18. There was a request to break that down by major service category. We're still working on that, as well as a couple of other data things that folks have sent in between meetings. Our plan at this point is we're still kind of working through some of those, and our plan is to try to compile that and any other kind of requests for data that come in and bring those back when we get closer to the data and transparency conversations. So I think it'll actually help folks see what we have available and help kind of lead to some conversations around what we might need to see or different ways folks might want to break that down. So haven't ignored that request, just want to let folks to know we're working on it and we'll bring it back in the coming months.
Okay, any comments or questions for Jeremy? Great. I'm trying to remember, was everybody here at our last meeting? Is there anybody on the commission who we've not had a chance to introduce here yet?
Jessica and Shannon.
Yes. Do you want to introduce yourself, please?
Yeah, sure. My name is Shannon Saldivar. I'm owner of Chandler Saldivar Agency, a health insurance agency in Wasco and Hood River County. I serve as vice chair of the Marketplace Advisory Committee, and I'm also on the board of our federally qualified health clinic.
Terrific.
Yeah.
Great.
I
Welcome.
I really appreciate the place at the table, and I'm looking forward to this work.
Thank you for being here. welcome. Great. Okay,
And Jessica.
And Jessica, please. Thank you.
My name is Jessica Gomez. I'm the CEO and founder of Rogue Valley Microdevices down in Southern Oregon. And I've done a bunch of different policy work, serve on boards and commissions and work groups at the state.
Great. Welcome. Nice to have you.
Thank you.
All right. Our next topic, I think we need to adopt our charter and our procedures, right? Michael, do you want to take that away?
Yes.
Thank you.
Good morning, everybody. During our last meeting, we shared with you a draft charter that includes a section titled Operating Procedures. And Ken, who is not here yet, offered a couple of edits that you could find in red line form on page 5 of the document that's in your packet. His proposed modification on page 5 to the committee principles is essentially that we should stay within scope and not wander from our scope. The other recommendation that he made is a little lengthier on page 6, and it speaks to OHA agreeing to support this body in good faith, and I would call out it includes language that says that OHA and staff will provide you with policy options for your review and discussion. We're going to start doing that today. But the options that are presented will not preclude you from introducing alternative policy options to those that are presented. Any comment on the draft modifications?
I guess I would just note for the record, I'm not sure, I feel like we need to be particularly directed to work in good faith, but we certainly would expect to do that.
Yes. Thank you, Pat. Other comments about these proposed edits? All right. So do we want to get a motion on this, Michael? Yes. Can I get a motion then to adopt our charter and our procedural approach as so moved?
Second.
Second. Any other discussion? All in favor say aye.
Aye.
Done. Thank you. Oh yes, I'm calling to see if Ken is on the phone, and who else would be on the phone?
Andrew.
Andrew, yes, sorry. Are either of you with us, gentlemen? Okay.
This is Andrew here.
Oh, Andrew's here. Okay, great. Good to have you. And Ken may not have been able to make it today. These are busy times for health plan folks, I'm told. I wouldn't know that. Okay, good. Our next item then is to get into this work of defining what total health expenditures are. And all I would say as we turn it over to Michael and Megan is, remember the adage, let's not let the perfect be the enemy of the good. And with that, let me turn it over to Michael. You're going to walk us through a series of slides that kind of help us understand what total healthcare expenditures mean and how we can get at it.
Right, and this,
Just a question then. As you're going through each slide, do you want us to hold comment till the end or comment per slide?
do not hold comment.
Okay.
Yes.
But use your mic.
Yeah, freely engage in conversation. So I just want to note that with literally the next slide, we will be starting a process by which we will be presenting to you a series of design questions and options that all relate to the creation of a cost growth target. And so we are moving in a sequential, elemental fashion. There will be a time where we will want to step back and say, what have we wrought through this process? But we're trying to walk you through a series of decision steps. The first decision has to do with how to define total healthcare expenditures. Because the cost growth target we are measuring something. The term that we are going to suggest we use is total healthcare expenditures. By defining total healthcare expenditures, we know what we will be assessing over time on an annual basis to assess what growth is. And there are a series of other questions that we will begin walking you through today, and we will continue to do tomorrow. You will find some of the questions appear not to be very controversial or difficult, There will be others for which the answer is a little less obvious as we go forward. So we're going to start with really an elemental one, which is when we say total healthcare expenditures, what do we mean? Okay, questions or comments? All right, so in all of these examples, we're going to share with you what does SB 889 say, if anything, on the question. We will share with you how have other states approached the question, and then we'll put options forth before you. If you don't like the options and you have another option you want to put forth, or a supplemental one, please feel free to do so. But we want to give you something to which to respond. So, Senate Bill 889 defines total healthcare expenditures as having 4 component elements. And I'll read from left to right. And Andrew, this is slide 7 that we're on. So the first is claim, payment, reimbursement for the cost of healthcare provided. And I want to note that these definitions are all focused on healthcare payments and not on provider costs. Okay, because some people might think healthcare costs, well, that's the cost to the provider. No, the perspective here is a payment that's being made and not a cost that's incurred.
So it's the actual payment and not what's billed?
Right,
Okay,
it's the actual payment.
thank you.
The second box, the one that's a little more mustardy, is other payments that are not claim payments. So there are payments that are made to providers that do not take the form of a claim. And this second category is for all of those payments, and that's a heterogeneous mix, as we will talk about shortly. The third box is cost sharing. So this is the consumer portion, because it is commonly the case that the payer is not making the full payment, the consumer is making part of the payment. So this is inclusive of all of those payments. Again, we're going to go into all of these categories in some detail. I'm just giving you an overview. And then finally is something called the net cost of private health insurance. It's a very wonky word or phrase, and I'll explain it on a future slide.
Michael, just to be clear, the employee portion of the premium, if there is one, is not part of this equation.
Right. No, this has nothing to do with premium. This is only about service payments.
Perfect, thank you.
So, as I indicated, for each of these categories, we're going to share with you what's typically the approach taken, or at least in 3 other states, and we'll suggest to you a definition, which you can then discuss and decide if you want to modify it in any way. Okay, so you can see, or on slide 8, we've already introduced a new acronym, that THCE, that's Total Healthcare Expenditures. So, so we want to be clear here, and it's probably self-evident, but one of the very concrete operational reasons for being clear here is in the future, information is going to have to be generated to perform a calculation. So a mathematical exercise will be performed to determine what per capita healthcare spending growth was over the course of one year to another. And so we need a very operational definition. And that's our goal here, is to be able to get to that. So I'm going to start with that, that box on the left, the claim payments. I do want to note that as we talk, we may at times reference another term in addition to total healthcare expenditures, and that is total medical expense. Total medical expense is spending spending that goes to healthcare providers, and that would be the 3 left boxes here on slide 10. Okay, I'm not going to use that term a lot today, but we might use it in the future, so I just want to introduce total medical expense is a subset of total healthcare expenditures. So, what are typical claims-based payments? So this is a list here. You will see that it is inclusive of services paid for by different types of payers, and specifically I'm referring to commercial carriers or carriers offering commercial coverage, to Medicaid and to Medicare. And some of the services are specific only to one. So, for example, long-term care in the top right, both facility-based and community-based services is primarily paid for by Medicaid. But because we are taking an inclusive approach to looking at healthcare spending, it is listed here. There are other services, hospital inpatient, that really span all of those categories. But I will note, and you can see there's a parenthetical in the right column next to dental and vision. We are listing services that are covered under a medical benefit. And so when we've got dental, we're not including dental insurance. We're just including dental expenses that are paid for by a medical benefit, same provision.
Nor are we including long-term care expenses when they're part of a long-term care policy.
Right, correct.
Good.
Michael, where would we be including mental/behavioral health costs? Is that
They would be in here.
other professionals?
Yes, it could be in other professionals. The categories that we have here are not sacrosanct. These align with the categories that are often used by the Healthcare Cost Institute, which manipulates a lot of commercial claim data. And I will note that for purposes of calculating what the cost, what performance against the cost growth target is, we're aggregating all the spending. So we're not for the purposes of that calculation. There may be other reasons why we would want to break out the spending, but for the purposes of that calculation to see how much did spending grow over the course of the year, we're aggregating everything together.
Would mental health and behavioral health be important enough to call out as a separate bullet point?
Yeah, we can make it clear that that's explicit. I will note that at the level of operationalizing this definition and giving that information, for example, to a health insurer, that would be abundantly clear. There will ultimately need to be something akin to an implementation manual that will have to get into all the nitty-gritty of that. But for purposes of our communication and to the public, we can add that detail.
Community health, what's in the bucket for the community health?
Can you guys speak up a little bit? So
Turn
we
your
can-
microphone on.
Turn your
Yeah.
mic on, please, Jenny, so we want to record this.
Question around the community health. The terminology for community health relevant to what's in the bracket? It's kind of confusing.
It is, yeah, it's a messy category. But the idea is essentially this is miscellaneous other services that would be covered by a medical benefit, commercial, Medicare, or Medicaid, that don't fit neatly into a category here. And again, this is all to give you summary level information that fits on one slide. If we wanted to give you something that was much more operational, it'd be way more detailed, and you wouldn't have it in that large font in 2 columns.
I have a question. I would assume all the 10 essential health benefits would be encompassed somewhere in these items. The core benefits that have to be included in ACA compliant plans.
It's anything that's covered by a plan.
Okay, yeah, so that would, I assume, cover all of those.
Yeah, however it got there, it's anything that's covered by the benefit,
Okay.
benefit plan.
A question. I assume that you spoke to an implementation manual, but where, so take for instance an ambulatory surgery center. So the facilities are only named here as hospitals. But there's non-hospital facilities as
Sure.
well, which I know is included. But I do think it'll be important that the terminology is important as we move through this work.
Yeah.
And then what would be for people who are not in healthcare day-to-day, what are the specific services under long-term care? Skilled nursing facilities, inpatient rehab facilities? Is it?
Yeah, but also all the Medicaid home and community-based services that are provided to persons with disabilities residing within the community.
So as we get deeper into the report that will be the output of this, we'll get very specific so anyone can understand that.
So can we, I just to cut this a little bit, can we just get an actual list, please? Because I think that I'm confused too, because you're saying anything that's covered by a plan. So which plan? A commercial plan, the Medicaid plan, the Medicare plan, long-term care?
All of them.
So if we could just get a list.
Yeah, so
that would
it's
be great.
anything covered by a commercial plan, by a Medicaid plan, or by a Medicare plan,
And then when you,
generally.
and then we can go down a rabbit hole of when you say commercial plan, do you mean my commercial plan? Do you mean William's commercial plan? What about Ruby's commercial plan? So if you could just give us a list, that would be super
We'll
great.
get a list.
Thank you.
Sure. Do you have a question or comment?
Yeah, just a comment, this is getting a little detailed, but on, so the dental and the vision, that's what's covered under a medical plan.
Right.
There are some medical plans that have 10 essential benefits that cover some dental vision services that would otherwise be covered, like routine services. They probably would be carved out. We're really talking about medical or dental services that are surgical in nature. Is that-
Well, so our intent is to exclude freestanding dental plans, but it sounds like there's a gray area
Yeah, there
here.
are some.
All right, so why don't we explore that
Yeah, okay.
with you?
And then I think this community health, it looks like it's just a term to define this category. I don't think we're really getting into community.
No,
Yeah.
no, it's something of a misnomer, but I'd say this is a catch-all category for things that don't fit in the other categories here.
Yeah, and as, the transportation is listed down here, so Medicaid covers non-emergency transportation, but commercial plans typically don't. So
Right, well, so this would be inclusive of both emergency and non-emergency as relevant to the payer type.
So is it fair to say it's basically anything the premium covers? So if you have, no?
No, so let me go on and I'll talk a little bit more.
Okay.
Because there are some things
Can I
that
just,
are.
can I just slip in here right quick? I
Sure.
want to make sure that we are being definitionally correct. I'm
Yeah.
using the word community health because it has a very different meaning, and I think we're going to confuse a lot of our audiences. So perhaps we need to, if this is what it covers, I think we need to be a lot clearer and more specific. The term community health means something very different, and I see people nodding, and so we can work on that.
Yeah, yeah, I think when we provide you with the super detailed list that you are requesting, we can do away with community health. I'll show you what's within the category.
Guys, I just remind us, we have an hour or so to get through this, and it's important that we let Michael take us through it all. There's a lot of detail here, and I appreciate that, and language is important, but the most important thing is that we get a working definition of what total healthcare expenditures mean in the next 45 minutes. So let's try to stay on track.
So Massachusetts, Delaware, and Rhode Island all adopted definitions that are inclusive of everything you saw on the prior slide. I will note that two of the states, Delaware and Rhode Island, separately break out primary care and specialty care spending because they want to track primary care separately, and I know that Oregon already does this in some fashion. But they have all chosen to be broadly inclusive of all of the covered services categories that you saw in the preceding slide. So, acknowledging that you don't have the fully detailed list, are there any major categories of covered services for Medicare, Medicaid, or commercial that you think is not included here but should be?
Comments, anybody? Yeah?
I would say I'm unprepared to answer this question, and I think that went to my first question. So I would not, I think when I think about home care for people with disabilities, I wouldn't have necessarily thought of that as long-term care services. And when I think about home care, I think of long-term care in different categories broken out separately, and I know in some states in home-based care and home health is wildly different than home care. So I guess I'm unprepared to answer the question, and it seems like other people, given the questions we have about this list, are also unprepared care. Maybe I'm speaking too much for the group, but.
No, I have the same concerns with it, because I didn't see dialysis. So we call out some things specifically, but others are assumed. And so it'd be nice to know what, so we're not assuming things are in
Sure.
or out.
Any other comments?
Yeah, Michael, what about health-related services that are allowed as
Great
Medicare
question.
expenditures under our waiver?
Great question. I don't believe any of the other states have those and thus have included them. So that's a great question for us. Massachusetts newly has them as part of their Medicaid waiver, but they didn't when they established the program. So what do you all think about health-related services and whether they should be included or not, specific to Medicaid right now?
Is there an example of that, guys?
You guys want to share?
Well, the apocryphal air conditioner.
Yeah.
Oh, yeah, right. Got it. Yeah.
So traditionally, that would not be included, but it's for Medicaid, that's a more defined service category than I think it is for commercial or for Medicare. So I think it's worth raising the question and talking about it and making a decision. And it doesn't have to be making a decision today, but I think it's a good question.
Yeah, I mean, I'm sitting here just not having thought about it much. I think I could make arguments either direction on, either we want to count it as part of the total, or we don't want to count it because we want to encourage spending that drives down other costs. And I'm not sure what the data would lead to.
Okay.
I think the intent, getting to the intent part, imagine we can spend all day to think about what's the exhaustive list to be totally inclusive of everything. But in this context of exercise, from a practicality perspective, if this section of the reddish thing is really anything what is claim basis. So yes, you may have cover or not cover, and you're unable to generate a claim for it, then it makes a practicality issue about how can capture that.
Right.
So this is really in each different section, it is reported, can be supported by claim adjudications, is all inclusive. I'm just cut to somewhere the practicality of that.
Yes,
Right?
that's right.
That's what we try to cover. Then getting to a question, so for in an innovation space, there are, let's say CMS today do not cover telehealth, right? It is a essential cost component for the providers. So you can generate a claim for it. So that kind of a funny ones, I don't think the industry is ahead of a sort of regulatory bodies. And I imagine how would that be treated here? So it's kind of two questions in one.
So, right, so if it's not covered and there's no paid claim, then it's not included in this category.
That's right.
Instead of cost.
Right, but if there's no paid claim, then that's it.
I think this is where it'll get a little tricky, is when we get into capitation, where you do those things out of the capitation payment. And so, right, but yeah, there's also claims that go along with capitation too, so.
All right, well, I would like to, so we will provide you with an exhaustive list, but to Jenny's point, we're talking about anything for which there's a claim payment.
Yeah.
That's pretty much what it is.
For category one.
For this first category. I think Pat's question about what do you do with health-related services when maybe there is a claim that's maybe there's a claim payment that's used for a food assistance voucher. I don't know if that's possible. I think we should make a decision about whether claim payments made by Medicaid for that purpose, and maybe someday also by commercial payers, should be included. Right, especially as there's more and more focus on social risk factors. I think that's an important forward-looking question. All right, second category, so that I can meet Jack's timeline. So non-claims-based payments. This is a heterogeneous mix of payments. So this is incentive payments for good performance, like pay-for-performance payments. It's prospective payments, so it's primary care capitation, behavioral health capitation, maybe it's total cost of care capitation. Payments often PMPM, but sometimes lump sum payments that are intended to support provider infrastructure to do care management, or for primary care practices to support a medical home structure. And then last, other support payments to providers and disproportionate share hospital payments is a good example of that, specific to Medicaid.
So some questions there. On the performance, there's an assumption there that those are incentive payments, and there's also negative payments. So, you know, there's pluses and minuses in that
Right.
category.
Mm-hmm.
What about research? So again, we have a lot of patients who come through our facilities. We receive, you know, we bill. There's a claim that goes out and we get a payment for research. For that portion of the
Who pays the
care.
claim, William?
The claim is going to get paid by whoever you've contracted with. So maybe a drug company, maybe it's a federal government research project.
So I can just tell you, in other states, research is not included.
Okay. Resident payments, paying for resident interns, in out?
So in the other states, the focus is what the insurers are paying. And so if the insurers have not paid a claim for research or for residents or things like that, then it is not captured. So there are costs and payments that are made from a hospital perspective that are assumed
Yeah.
in the payments made in general, but not specifically called out for.
Okay, because there are things that are taken off the bill that the payer, I mean, normally, if it's research and it's experimental, you know, somebody else is paying that and the insurer doesn't. So I mean, I just want to make sure I understand.
We're only looking at funds that are going from the insurer, Medicare, Medicaid,
Commercial.
and commercial, and then the associated patient share if there is one. So in Massachusetts, Delaware, and Rhode Island, they require reporting of these categories. Number 3 is risk settlements, so that would be both positive and negative, potentially, payments. Care management and other, I would say, infrastructure support payments related to care management. Recoveries, that is recoup payments. And then there's another category, and disproportionate share hospital payments would fall here, along with other miscellaneous payments.
Makes sense, folks? Yeah, good.
So, are we missing anything from these categories?
Would reinsurance be in number 6? Other? Can't hear you. I said, is reinsurance included in?
Reinsurance that an insurer purchases?
Other, right, yeah. It's a cost.
So, no, it would not be included here because this reinsurance is not a payment to a provider. But we'll get to reinsurance potentially being included elsewhere.
In health plan administration, maybe.
Right, it fits into another category, but not into this one.
Okay, great.
Okay?
And just to clarify, included in this on the commercial side, you know, in the MLR calculation, there's the quality improvement component of it. Would that be kind of explicitly included in this as well?
No, it's not a service payment. It fits elsewhere, and I'll show you where, but it doesn't fit here.
Other comments or questions, anybody? Okay, let's keep going.
Okay, so the third element of our definition of total healthcare expenditures is the cost sharing that individuals are covered, incur, so co-payments, deductibles, co-insurance. I think it's commonly understood. I will note, though, that consumer out-of-pocket spending associated with non-covered services is not included here. Or consumer expenses for non-healthcare services discounts that an insurer might offer. So I think we had a question about this maybe earlier. If there's some non-healthcare benefit, then any costs associated with that are not included. I also want to note that healthcare costs paid by individuals who are uninsured is not included oftentimes when we've had this conversation in other states, people will say, well, what about bad debt? What about a hospital's bad debt? So a hospital's bad debt is not included here because that is not payment that's made to a provider.
Right.
Okay, so that's why
Well,
it's not.
I do have a question then about that, because what we're using as the definition is allowed,
Mhm.
right? So,
That's right.
So, and we typically run, I can just talk about our health system, we run around $16 million a month in between bad debt and charity.
Mhm.
So if the assumption is that we're collecting all that money, I think it's a false assumption.
Well, no, there's no assumption that you're collecting that money because there's no payment associated.
No, but if you're using allowed as the out-of-pocket that people are paying, assuming that
Oh.
that is the other piece that we're collecting, we are not.
Right.
Yeah.
Allowed
And so-
from the insurer to the hospital.
When
Right.
someone doesn't pay their co-insurance.
Right, and so as an example would be, as we move now to the 400% of federal poverty limit for charity care, we're gonna see an increase in, the assumption is that we're still collecting that, but we're not. So, and that is growing exponentially as healthcare costs grow with it. So I just don't wanna lose that.
Right, so allowed expenses that are not actually paid by the current individual, they are included. Charity care delivered to somebody who's not insured is not.
Well, no, that's,
Yeah.
because charity care applies to the insured as well, so it's not for
Okay,
those
in
that
some
are
other states,
uninsured.
they're
It-
distinguished.
Yeah, in our state, it applies to the policies.
Okay, so then I should say, cost sharing related to people without health, for people without health insurance is not included.
But
The cost sharing with people with health insurance that you read off as bad debt is
Is.
also not included.
Is included, because that's part of the allowed definition. So we're looking at, we are defining total spending as being what in insurance language people refer to as the allowed amount. So that's what's paid less the amount that's supposed to be paid by the consumer, but which, as you know, is not only paid by the consumer.
Right.
So
Remember that we're trying to get to about 90%
Yeah.
of everything, and we're trying to come up with a formula and a methodology that we can replicate year in and year out.
yeah, and I just want, again, Jack, I just want to make sure that we've considered that when we're looking at that
Yeah.
90%, because it is a growing number.
Yeah.
And then,
Yeah,
That's fair.
can I also, on this piece, I feel like on the categories typically excluded, that is just typically excluded. It's not, people have a variety of health plans, and then we have the prioritized list. But in the commercial plans, a lot of the prioritized list may not be included in
Yeah.
your commercial plan. So you're out of pocket on things that, on here, non-medical cosmetic surgery is obviously excluded. However, a lot of commercial plans exclude medical cosmetic surgery that people are paying out of pocket for, or.
Yeah, we're not,
That's out.
so the goal here is not
That's
to try to do an insurer to insurer exact or policy to
Yeah.
policy exact calculation. We're simply saying here that if a consumer incurs expenses for services that are not covered by the policy, that's not included in the definition.
Is that, and Michael,
So I guess-
is that a practical issue, just trying to collect that data?
Highly practical.
So it's a practical issue. So there's no ability for us, because we have the prioritized list, which is unique to our state, to collect that data on a broader level to show services that individuals have paid for that are on the prioritized list as included in our healthcare expenditure. Because I think that there's two pieces here of payers, right? There's the individual payer, then there's the insurer payer, and we're wanting to reduce the costs on both. So excluding or reduces my dream, but maybe not letting those costs grow on both ends. And so then having a bunch of commercial plans to meet their 3.4% cap start excluding additional services is not where we want to, is not the goal here. So I guess I would like us, I know that what the recommendation on the table is, I would like us to think about this more tied to the prioritized list than maybe some other states have.
I'm not sure
Yeah,
quite
this-
what that means or how we could operationalize that, but I appreciate your comment. You have a reaction to that?
Well, I'm thinking of Ken's language that we just adopted about scope. This feels like it's an interesting analysis, but it's outside of our charge, right? It's an analysis that's got relevance, but I don't think it fits within our scope.
Well, I think
I'm sorry, can I, so I believe it fits within our scope to reduce costs for the individual as well as the insurance plans. So I guess I would take exception that I believe it is in our scope, and I don't want us to create a plan that is measuring, that's setting a cap that then we can just continue to push on to the individual. That is not our goal.
No, that's not the goal here.
And that is well within our scope.
This may be something that we can talk about during the quality piece that eventually I'm thinking that we're gonna discuss, is sort of where does those things kind of fit when you talk about kind of quality of care and what that looks like as we reduce costs.
We do have time scheduled for future meetings to talk about whole data analysis plan, including looking at quality. I also just want to note parenthetically that we are talking about setting a cost growth target, not a cap.
Yes.
There's an important distinction.
I will own that I said cap. I will own that I said reduce costs. And that we're really talking about a cost growth target, yep. It'd be great to see reduced costs, by the way, I'm just gonna put that out there.
Speaking of Ken, I just got a text, he's on the phone, he can hear us, we can't hear him.
Oh, all right.
I didn't ask him that question, so you had
I'm gonna try, why don't you guys take that off? We have to keep moving here. Okay, come on.
So, Matt? Yeah, okay.
I think by large, the cost sharing component is already included.
Right.
Yeah,
Right.
the technical definition.
Right,
already.
so
So therefore, this is really for informative, to impact the audience purposes. We want to make sure we have clarity within the total allowed.
So for insiders, yes, this is all allowed, but for the general public, and perhaps for some of the people at the table who don't use the word allowed all the time, we are distinguishing the cost sharing from the amount that the provider receives. But if you put them together, that equals the allowed amount. And in fact, Massachusetts, Delaware, and Rhode Island all are using this allowed approach.
Yeah.
I want to be very clear that it's not additive for buckets. It's
Mhm.
really for the clarity and transparency.
Yes. Right.
I think what could be helpful is we get into the more detailed list of what's in and what's out, especially the stuff on out-of-pocket costs. I think we can delineate that stuff and then come back to the discussion around, is it possible to collect any of that data and what would it take as part of the data and analysis section?
Great. I had a question, if out-of-network services are not captured anywhere?
They are.
They are.
So it's a payment made to any provider.
Okay.
In-network, out-of-network, in-country, out-of-country.
Well, so a lot of
We
our
haven't gotten
carriers
there yet.
are EPOs.
Oh, yeah, we haven't, well.
Okay, but on these, so a lot of our carriers are EPOs and don't make any payments for out-of-network services. So if you happen to fall out-of-network, you get nothing, and the consumer gets stuck with that whole bill, even if you have insurance, so.
Right, so that's a non-covered service.
Okay,
So it's not included.
okay. Now that'd be the majority of our individual plans right now, so important.
Yeah, it is, yeah, but it's not in the denominator.
Okay.
Yeah.
Jack, by the way, we are doing fine on schedule.
Good.
Just so you're
Great,
aware.
thank you.
All right, so should we make any modifications here?
Question, so we've gone by several things where we've said sort of in, out, and talked about trying to get to 90%. Do we have some way of sort of keeping a rough eye on whether in fact we've gotten to 90% with some of these, the one that Shannon just brought up particularly, maybe concerns me that it's the kind of thing that could have a magnitude that really is important. How will we try to check for that?
So the hardest thing is to get at healthcare spending that's happening by the consumer that's totally outside of the benefit, because we have no way of knowing what that is.
I think what we can do as part of our analysis of breaking down service categories and kind of go back and check with what percentage of overall service categories we're trying to get to. What's the stuff that's maybe we're saying is out, and is it in the big slice of the pie, or is it in the small slice of the pie? And try to do some tracking of that.
But some I think are easier to quantify than others.
So some stuff we just may not know.
Right.
I guess I just want to put a marker down for, I'm concerned that we keep an eye on that issue, because I think I agree with Felice's overall point that we don't want to create a perverse incentive that having more of that stuff is a way of trying to achieve the target.
Yeah, well, I think all of this speaks to the desirability of creating an analytic structure to assessing the impact of the cost growth target and whether there are unintended consequences. And if there are, picking up on them really quickly.
So as it relates to unintended consequences, and thank you for using that word, that's mine. I wonder if claims that are being kicked out, there's a way for us to capture those so that we can answer that question. It may not be the broadest spectrum, we may not be able to have super accurate data, but we will have some data so that we don't move in a direction that does create unintended consequences when we have all of these things falling outside of our intention. So claims that have been put forward and were denied might be a good way for us to look at that.
You're not talking about non-covered services, Ruby. You're talking about claims that were denied as not being medical necessity, kind of, as an example. Okay.
Which, Jack, that's just going to get into a whole different conversation around social determinants. I mean, a lot of the denials we get today are because we have no safety.
I understand that. I remember the goal here is to come up with a reasonably accurate way capturing 90% of the cost that can be repeated year in and year out to set a per capita growth figure. That's what we're trying to achieve here. There are a lot of problems that we're acknowledging in the system. And the problem is if we try to account for every single thing, I don't think we have a way to capture that. That's
no, we don't. But I mean, I think that comes later around why our costs going up so much.
I think you're exactly right.
Yeah.
I will share, and this may provide no consolation whatsoever, but since Massachusetts implemented their cost growth target in 2012, there have been no allegations of negative unintended consequences that have resulted. Only positive intended consequences.
Yeah.
Okay, again, that may not make any of you feel any better, but I wanted to relay that information nonetheless.
Good. Okay, let's keep moving.
All right, so any additions to this?
Just my one comment again, that we consider the bad debt and charity here, so it's just not, that's not just the definition.
Okay, so the fourth category is something referred to as the net cost of private health insurance. This is focused in its application in the other states on commercial insurance, and specifically on the difference in the value between earned health insurance premium and benefits. So it's essentially the administrative costs incurred by an insurer, and it's any profit or for a nonprofit contributions to reserves, or could include losses. In the other states, they are measuring this by gathering data from federal financial reporting forms that insurers utilize through the National Association of Insurance Commissioners. And these other states calculate the net cost of private health insurance on a per member per month basis for all of these market segments that you see here. Massachusetts, Rhode Island, Delaware do not apply this to Medicare or Medicaid. It would probably be hard to apply it to Medicare. CMS would have to provide a lot of information. There are administrative costs that are required to administer the Medicaid program, but each of those states made a decision not to include those and focus only on the commercial insurance costs.
So this would include things like risk corridors, risk adjustments, public reinsurance, those kinds of things as a netting effect?
It does, public, well, so let's go through them one at a time.
Oh, well, so, in Medicaid for, Hep C drugs, we have a risk corridor program, to balance out the incidents across the different coordinated care organizations. So would that be would that have a netting effect on these kinds of costs?
So that's a service payment, right, for Hep C drugs?
No,
So-
it's a risk adjustment based on CCOA had 5 times the expected incidence of Hep C cases versus CCOB. And so we net out the payments to those CCOs based on that incidence.
So the premium to the CCO is modified.
Correct.
Based on that experience. That Hep C spending is what we're capturing
Okay.
because the CCO is reporting on their spending.
Got it, okay.
Just a terminology question. In the context of this category, can you help explain the use of private health insurance? What is meant by private? Because
Yeah, so we didn't invent this term. It was in use in the other states. And so I don't know the origins of it. I assume, though, it was meant to distinguish public coverage through Medicare and Medicaid.
well, except we're saying Medicare Advantage. I mean, it's the administrative costs of an insurance company that
Right.
delivers a Medicare
That's
Advantage
right.
or is a CCO.
That's correct.
So, I'm just calling out, it, sometimes when people talk about private health insurance, you think only of commercial, but this is
Mhm.
broader
Not
than
quite
that.
here.
So it's really about that these are non-governmental insurance companies.
Yes.
Providing coverage.
That's right.
Can you walk us through how that works in the self-insured market?
So either on the federal MLR or the supplemental healthcare exhibit from the NAIC, so the insurers are required to report to both of these organizations. It is essentially the cost of, I forget the technical financial term, some of you may know. It is the fees incurred from uninsured plans, so it's the employer fees to the insurer.
It's the TPA fee in essence.
TPA fee, yeah.
Question really around the inclusiveness in the context of a total health expenditure. So this is just about commercial, and we know in the industry cost shift. And just because the technicality not including the Medicare and Medicaid, which most plans, it is part of the total cost, and just look at the commercial itself, it started to go down to the rabbit hole of what is total.
Well, this is just for the administrative expense. So
So
Medicare,
not including
Medicaid.
margin. We talk about, this term you read it as admin plus margin.
Yeah, admin plus margin.
Right, therefore, it goes into the bucket of a cost shiftation within the line of business. I'm saying that, just look at the commercial itself.
Yeah.
We are now truly representing the bulk of business from a total cost.
For the admin. I'm still not sure I'm following.
For the
you.
margin.
For the margin, right. But this includes what the margin might be for Medicaid CCO or a Medicare Advantage plan.
No.
Mhm. Yeah, what it doesn't cover are the administrative expenses of the Oregon Health Authority to run the program.
Of course not.
The only reason why these are split out is because you have to calculate them separately using the data sources that the other states are doing. But essentially, it is premium less claims for any insurer that is not a public government insurer.
So let me just get more technical here. Is it talking about stat-based or gap-based?
Oh,
Because
I don't have the qualifications to answer that question.
What was the question, Jenny?
Stat
Was-
gap.
Oh, yeah, I don't know.
It's whatever's on those federal forms.
Okay.
Michael, I'll just say, I don't know what the origins are of this, but this is something that's collected and reported at the CMS level across Medicaid and Medicare commercial as well. It was part of the analysis that came out this last week of 2018. They broke out net cost of private health insurance for all states and nationally.
I had
question, backing up unfortunately a little bit to the kind of consumer's cost slide and why premiums were excluded from those costs when kind of administrative costs from carriers seem like they're included in these slides.
So the focus on spending is looking at what's paid for services. Okay, the premium payments are to include the services and this admin, but the premium is essentially a projection of what spending will be. What we are measuring is what is actual spending.
Exactly.
Other questions or reflections on including what's called the net cost of private health insurance, but in lay terms is the administrative cost of the insurer plus any margin or loss for all lines of business. Okay.
Michael, just to be clear on your last comment, if somebody has $100 premium and the medical loss ratio or the medical cost falls to $74 and there's a $26 admin plus margin, that admin and margin are both collected, not just what the carrier put in as their administrative cost. Margin is in there. So if carriers are making tons and tons of money, that will be captured in our knowledge.
Yeah.
Yeah, okay, good.
And if that individual had $2,000 of spending on $100 of premium,
That's captured
also
too.
captured.
Perfect, okay, just sort of clear. Thank you.
Okay, should we make any changes here based on what we've shared?
I have a comment. I mentioned this last time too, the premium taxes, some of that feels like it's out of our control in Oregon. So I just think it's something that, say there's some federal taxes or something like that, how we might keep that. Are we managing to that?
Yeah, well, so one could and people do make the argument that not everything included in this fully comprehensive definition is controllable, right? But, right, I mean, there are debates. It did not happen in our conversation today, but like bodies to this have said, well, why are we including pharmacy? We can't do anything about pharmacy. Without judgment, this is being inclusive of everything, recognizing that some of the spending that we're capturing is more easily influenced and some less easily.
Exactly.
I'm just wondering, as a call out, just again from the insurer's side, is the complex care management that they do as well, just to, that's noted, that's part of that overhead cost they incur as well.
Okay.
That's in a different category.
No, that's.
No, insurer-provided care management would be an add.
Right.
Yeah.
So I think the other thing I would just add is so while we're diving super detailed into exactly the definition of these things, they're not reportable in an easy fashion at this level. I don't think that OHA wants to get into the business of reporting the advertising, the premium tax. I don't think it's actually collectible. And so while this is included, when it comes time to do an analysis to say, geez, net cost of private health insurance soared last year or went down, then I think there's another conversation to say, well, what could it have been? Did we have new taxes that were put upon us? Did we have an increased number of complex patients that required care management?
Right.
So we have gone down into a deep level, but we have to also remember that it has to be thought about at a higher level too. And so both conversations are good, but they can get kind of mushy.
Can I ask for something just for me? I
Sure.
feel like there are a set of rules around insurance that I don't quite grasp around medical loss ratios for insurance companies in the state of Oregon, the things that DCBS measures when they do rate review, those type of things. Could we get like a one-pager that address some of these issues that I think
Sure.
might...
Like a language, sort of like a vocabulary, you mean?
Not
what these things
necessarily
mean?
like a vocabulary, like I know that there's an administrative, like a medical loss threshold that you're required to meet. I don't really know what that is or
Okay.
how that relates to this. So saying that the $100 and then the 26, I was like,
What does
is that
mean?
even
Got it.
legal? Right? So then
Sure. Well, I'm looking at Zachary and the staff, and we will come up with some materials to get out to the commission to help kind of understand that world a little bit better.
Yeah, that would be great. And
But I will say, Felisa, so our attempt here is to capture the spending, whether someone met or didn't meet
Sure.
spending ratio requirement.
Yeah, I get that portion of it, so that's really helpful. And I think I don't understand I don't understand the insurance rules to be like, oh, that's totally fine or not fine, or and
Okay,
it seems
yeah.
like we're gonna have to make a decision about
Sure.
that.
We'll get you a one-pager that explains all the insurance rules.
Andrew's working on it
It's
right
like
now.
super tiny.
I hope you can put it in your car.
And the magnifying glass to go with the one
Yeah, yeah.
pager that explains the insurance rules. And then the other thing that I think that would be helpful for me is I read a lot of stuff about the impact on the Massachusetts impact on providers and the health systems. What I haven't seen is anything about the patient payers. So I haven't seen anything that's like, what has been the impact of individuals
On
in
their costs.
Massachusetts on their costs.
Sure.
So it'd be helpful to see some of that, to your point of like, people
Yeah.
love this.
Okay, we'll take that back. Thank you.
The last piece I can answer, I mean, Massachusetts this last year in their cost trends hearing actually reported out of consumer spend versus overall spend, they met their target on the overall spend, but consumer spend still grew something like 6%, so that's something that they're diving sort of more into in the
To your
next
point.
phase of the work, so
Yeah.
your point earlier.
Got it. Okay.
And it varies from year to year in Massachusetts. There are some years where the commercial spending is less than Medicaid, and there are other years where it's not. So when we shared Massachusetts data last time, we showed you the aggregate, but if you break it down by market segment, it moves around from year to year.
Okay. We're doing good on time.
I just had one more comment to Megan's point. So, and if it's helpful for folks to see the Massachusetts materials at some point, we can send those around. But I think what Michael and Megan are alluding to in terms of a manual, and literally there's a spreadsheet that goes out to the insurers, and they say, add all of these things in. It's not like folks are reporting out on every line of business to the state. Now, as a group, you can decide you want us to collect it at that level of detail, but really they're just giving the carrier the formula, calculate all of this stuff in, and then report it at an aggregate level to the state.
Yeah, so I want to step back from the trees for a minute and look at the forest. So the conversation that we're having today, and that we'll be having at the next meeting as well, is really about how to define the cost growth target and how to set the target for aggregate spending. It's not to understand what's driving spending, or why is there variation in spending, or any number of policy questions. We will, later on in our process, have a separate conversation about what types of standard analyses would be helpful to interpret performance against the cost growth target. We're not doing that yet. Right now, we're just looking at total spending, and we are deconstructing today so that we can then build something that's going to be aggregated so that you understand what's inside of it.
Yep, well said. All right. Let's keep moving.
Okay, so last part of this discussion is prescription drug rebates. Prescription drug rebates are important, but you may note that they don't easily fit into, or obviously fit into, these four categories. And so we're going to talk about them for a minute. So what are prescription drug categories? This is so you don't need the one pager, Felisa. I'm going to give you a half pager right now. And for anyone else, not
I know drugs.
You do? All right. So these are payments that go back, little rebates or other price concessions that pharmacy benefit managers and health insurers get from drug manufacturers. They are a lot of money. If this was a small amount, we would say, don't worry about it, it's too complex, but it's a lot of money, which is why we have to think about it. So this is from Massachusetts annual report looking at pharmacy spending. And you can see here total pharmacy spending and then pharmacy spending net of rebates. And the rebates are enormous, as is the pharmacy spending. And so this is why there's reason to spend some time thinking about how to address pharmacy rebates in the context of calculating a cost growth target. So, in the 3 other states, payers are required to report.
Quick question.
Yeah.
Is that inclusive of only the pharmacy rebates from PBMs, or is it inclusive
Right.
of
So
340B payment rebates as well?
No, I don't remember the 340B rebates. How do we deal with it?
It's Medicare reimburses those
Separately.
separately.
Yeah.
Yeah, okay. So in these other states, total healthcare expenditures is reported net of rebates. Now in Massachusetts, they've got a statute that requires their data agency, the Center for Health Information and Analysis, to study drug rebates. They do a bunch of sophisticated analyses requesting supplemental data from health insurers to understand drug spending and rebates. But they don't do that in Delaware and Rhode Island, and simply they ask the payers, including Medicaid, to report the rebates that they receive, and then that's used to adjust down total healthcare expenditures. Okay?
Right.
Can you help me understand if we are including margin for the insurer, do the rebates not contribute to their margin? And so are they, in essence, captured in there? They're just not characterized as a rebate, they're characterized as margin? Is my thinking accurate? It must not be.
No, that's what I was thinking.
Okay.
Yeah, we're not trying to follow the trail on the rebates. We're just trying to make sure that we don't inflate the cost of total healthcare expenditures by not recognizing them.
Yeah, I think one of the challenges right now, so we have gross payments in the all-payer claims database. We don't have rebates. So we have an idea of how pharmacy spending is shifting, but it's not really accurate because we don't know what the actual spend is net of rebates. So I think that's a question, is if we want to accurately report out what the trend, by major categories, at some point we want to build a trend, we want to be able to map out, how is spending happening in pharmacy versus other categories. I don't think any of us could with a straight face say gross is completely accurate.
This graph shows you how much you're overstating spending if you're just looking at claims without rebates.
Hey, Jack, can you hear me now?
Yes, Ken, we can. Thank you. Good to have you.
Use your area. I think I dialed in the wrong number.
Yeah.
So anyhow,
Yeah.
this is an area that I think could be material. I'm worried, particularly in a large self-funded segment where you have a lot of PBM carve-outs and a lot of this running through brokers. I wonder if the other states have done anything special to capture that data.
So no, they have not. If there is a carve-out on pharmacy, the insurers in the other 3 states have been asked to make an estimate, but with respect to rebates, there's really no ability to make that estimate. So rebates are not included in that, but there is an estimate for the pharmacy spending. So there's some challenges there because they may be overstating anything that's been carved out.
Right, so, we're trying to be as inclusive as we can be, but there are some things that are just simply, the level of effort that would be required to chase it down is not worth it.
I have 2 comments, kind of somewhat related to what that comment. The pre and post is more of a transparency issue, and frankly, technically can go both ways. Any given year's rebate is trending at a faster pace than the total drug. It just makes your whole excise wonky and the sizable impact. That's one. And that's actually less relevant. The real issue of rebate payment total. To break down into a claim base, that's get down to the data requirement, it will be almost wonky. Right, so just want to tee out the real feasibility issue about, and get back to the intent.
Yes. Okay.
Just to support that, the tracking rebates is incredibly complex, and if you have a large self-funded book of business, most of your customers actually receive those rebates, so it's fully insured, it's different, it's just really challenging to generate.
So other states have had to wrestle with this, and so Megan, why don't you explain?
Well, yeah, I mean, in some sense, the insurers are who's wrestling with it, more so than the states. So in Massachusetts, there's a pretty detailed specification on how to identify what the rebates are, and in the other states, they're being reported on an aggregate and on a per member per month basis. So the states don't have a ton of insight into exactly how they're estimating it, but are hoping that they're doing so in good faith.
So I believe that during the last short session, there was a bill being discussed and kind of making its way through the process having to do with drug pricing transparency. And this was all really part of that, trying to better understand the rebate structure, what the true cost was, and then having some disclosure around how that was done. And I don't know what happened to it, if it's still kind of.
Funny story about that.
No idea. Surprise.
It passed and we're being sued.
Really?
We
Yeah.
collectively.
Really?
It, it's not, unless I this wrong, it's not all pharmacy spending in the state, it's limited to some specific high cost drugs, so it's,
Okay.
again, sort of an incomplete picture.
Thank you.
And I believe we were told, stop.
Okay, let's keep
So,
moving.
so I just want to come back to, so how do you operationalize this? Well, trying to get it at an individual level. So I think probably what the other insurers are doing is they're looking at the total value of the rebate, and then spreading it across their book of business on a PMPM basis. All right, so I just want to affirm that you all think it is worthwhile to include pharmacy rebates in the calculation.
I believe we do.
Okay.
Yes, is our agreement on that? Yes. Yeah.
Okay.
Good.
All right, noting that you're actually ahead of schedule.
Wow.
Because of Jack's aggressive facilitation of this one. So I'd like to pause right now, because where we're going to go next is to talk about whose spending are we going to be capturing. So we've talked so far about what is the spending. There are the 4 categories, plus drug rebates. The takeaway that I have is you would like to see additional detail on what are the services that fit within it. Although, to Jenny's point, at the end of the day, it's anything for which a claim is being paid.
Yep.
Right? But nonetheless, we will provide you with some greater service definition. Are there any other broader questions, requests, or reflections that you have on this conversation of what do we mean by total healthcare expenditures?
I might need to maybe go offline with somebody, so I'm still hung up on, from a consumer looking at this work we're doing and their cost, their premiums are gonna be a huge piece of that. And so I don't know if taking everybody's time for me to figure that out is most appropriate, or going offline with somebody, but I know that's how consumers are gonna feel, right? And so looking at that, it's then gonna be challenging, well, not really that cost, but these costs, so.
No, I'm glad you're bringing this up, because this
Yeah.
is a challenge with setting a cost growth target.
Yeah.
Because sometimes ultimately you're going to recommend a cost growth target of X percent. And hopefully that gets some wide publicity and has some impact. But an individual consumer is going to come to you and say, well, wait a minute, I thought there was a target of X percent. Why is my premium going up Y percent?
Right.
Okay, that's a very complicated story to explain.
Yeah. Well, and I would say, obviously, it wouldn't be directly proportional, right? Like your particular premium wouldn't be capped at that 3.4%. I can totally grasp that concept. The piece I'm missing is why their costs weren't even included in the data we were looking at in the first place.
So the spending that underlies the premium, or that was anticipated by the premium,
Right.
that's what we're capturing, is what was actually paid out, not what was projected in advance when setting the premium.
I think there's two things here. So one is what are we spending on healthcare services, and that's one bucket. We might want it, the group wants to collect data that helps us understand trends of what that impact looks like on the consumer level. It might, but you just have to be careful not to double count them, right?
It should be the case that if you set a cost growth target that has an impact in slowing spending growth, it should be the case that premium growth over time
Will slow down, totally, but I guess I'm looking at a consumer's feeling like part of what their costs are that premium.
Sure.
And maybe it just can't be counted because it's wrapped up in the commercial side, and again, you're forecasting. But for a consumer, what I'm paying right this minute is what's relevant.
Yeah.
You know, so to not even have it listed anywhere seems like a miss to me, but maybe I'm just not, maybe I'm missing something.
Well, if it was included, it would be a huge double count, because we're capturing the spending that followed the issuance of that premium.
Mhm.
So we would really be counting spending twice if we had both the premium and the spending that was done under the premium.
But what we could do when we get to the, what do folks want us to collect and analyze and report out, we could have categories of what's happening in terms of consumer out-of-pocket cost trends. It's sort of separate from the bucket of where is all the spending going.
And I think this also illustrates that there's a pretty big communication component around this work about how we explain what it is and what we're doing and what it does and doesn't do, and issues like that of what are we counting in what kind of place, so that, you know, average people can see this work and kind of make heads or tails of it.
I would think, you know, part of that too is gonna happen as we look at the transparency piece, because then you're gonna really see how do costs align with premiums, right? And if we don't see some, you know, some stymie premium growth there, you know, then that gives us at least some data to figure out how to address those things when we go in.
And the other states, interestingly, have not taken a consumer-focused communication approach to this policy. And so this is a policy that's really well understood by the types of people who largely constitute this table, but consumers, do they know about this? Are they following it? Not super closely. And it's because it's really technical and hard to grasp. But that doesn't mean that you shouldn't develop that approach.
Right.
But for the reason that you're indicating, it's hard to find a way to do that effectively.
Well, I think the risk is that people are watching what we're doing. I mean, people are excited about what we're attempting to do, and I think if we don't have a communication strategy around what this does and what to expect, people are not going to feel very good about the work. And so we need to make sure that we do a good enough job at helping to educate people and keep people up to date as to how this really applies to them as individuals.
And there's a way to do it. The CEO of the Blues Plan in Rhode Island recently went to go speak to the employer coalition in the state. And she is the co-chair of their equivalent to this body. And she said, Michael, I need talking points to help people understand why this doesn't equate to their premium.
Michael, was there, where did other states place the costs associated with medical malpractice? Was that under administrative costs on the?
So that's not captured. So this goes back to the point I made earlier. The focus in this definition is on expenditures, not on the costs of providers. There are lots of provider costs. Those are not captured. We're only looking at payments that are being made to providers.
Okay, so Michael, I want to ask you, do you want to try to get a decision on this before we talk about the who? This is about the who's going to be included as opposed to, this is really about what's going to be included on the medical expense side. Do you want to try to deal with that first? Or do you want to try to deal with both?
Yeah, so my general sense is, I mean, what I picked up from Felice is I want to know, and not only Felice, but from others, I want to know more about what the services are. So we will provide that.
Okay.
My sense is that otherwise, there seems to be general comfort with these four categories plus the drug rebates as being an organizing.
Perfect.
Is that
generally right? Okay.
So we'll come back next time and have the additional data to finalize things, right?
Okay, perfect. So do we want to take a break now before we get into the who? Why don't we do that? Let's take a 15-minute break, and we'll come back and start talking about who we're going to measure. Thank you. Are you still are you mostly or are you mostly I want to know
Everybody's like, oh gosh, she's asking. No, I know I need to start reading them and then I'll have
Zero.
Well, how about the kids? I used to work at a place where I would be bothered here.
I guess
You get to a certain age, you're gonna get it. I
and it's hard. So just at least me being able to there's some kids that say just, yeah, it's fun. I'm having fun. Oh yeah, I know, I got a lot of room. Yeah.
every day. Good, we just had a meeting last night. For the success act, well, next year. However, we also just discovered that we have a problem. So now we've got expectations for student success. Enrollment shortfalls, incurs, costs, and marketing.
Some OHA meetings I go to Bosco. They're like, you know, if you're coming around after 20 minutes.
Well, the growth rate is slower than expected.
That's how you
And part of what it is we had a explosive growth, and then no growth during the recession, and now some growth. And that explosive growth period now is, my neighborhood had 40 kids on the block when we moved in, and now it's 20. 20 is still plenty of kids, but it's not 40. Yeah. And so that kind of stuff is housing, demographics.
That's right.
Yeah, we should be young. I barely do.
Well, some of it. I can-
once.
Yes.
We make sure folks speak into the microphones. I know it's a little awkward, but folks away from the table are having a hard time hearing us. And then turn your microphone off if you aren't speaking. I'll keep the background noise down.
Great. Okay, so Megan, are you going to take us through the who's
Sure.
going to be in the pool here?
Happy to.
Okay, thank you so much.
All right. Okay, so sorry, I'm just gonna, this is not intuitive. Okay, there we go. Sorry about that. Okay, so our next part of our conversation is really gonna be about whose total healthcare expenditures are we measuring? And when I say who, I don't really mean in particular individuals or populations of people, but I'm thinking about it in terms of how, about coverage, about how people are insured. We talked a little bit about why there are some reasons folks without insurance are difficult to capture their spending in this, but we're gonna think about it in terms of their coverage. So we're not talking about particular populations of people, which might get confusing in a second. So SB 889 didn't provide specific guidance, but it did say that, I think the intent was that all Oregonians' healthcare spending would be measured. But that's easier said than done when it comes down to the level of detail. So we'll be talking a little bit about the who. Now, originally when we were thinking about this, we know that data access to certain populations can be challenging, and when we designed this slide, we said we were going to discuss the question without consideration of how to obtain the needed data, but I want to scrap that because I think that's a very real issue, and we do need to think about that when we're thinking about who to include here. Now, we may have to come back to you and do a little bit of research on particular populations to see how and if they can report data, but we'll get to that on an individual basis. So when we're thinking about the who, it's about the sources of coverage. And here is generally the population of covered individuals as we can see it. I shouldn't say all covered. Individuals who receive health care for which health care can be measured. So Medicare, both fee-for-service and Medicare Advantage. Medicaid, which would be the CCOs and fee-for-service. Commercial, both fully and self-insured. The Veterans Health Administration, which would be spending by the VA. FEHBP, which is probably rolled into a commercial insurer's plan. FEHBP is the Federal Employee Health Benefit, and I don't know if there are multiple plans in Oregon or one plan that tends to cover the FEHBP, but it's offering the insurance products for federal employees. TRICARE would be the insurance benefit for those in the military. The correctional health system, so the state pays a lot of money for individuals who are incarcerated for their health care, some of which is captured under Medicaid, most of which is not.
Is that state and county or just state?
I will say that no state has included correctional health systems yet, and so it would be up to this group to decide whether it would be county and state. So, but it would be any health system, payments, essentially, I think is the idea. And then Indian Health Services. So we have a list of pros and cons for each, and I thought what we could do is walk through each category and talk about them in particular. So Medicare, which would be fee-for-service and managed care, the reasons why you want to include it is because you would be inclusive of that population, and it represents a significant number of individuals who are, a significant number of Oregonians, that is. A reason you might not want to cover it is because the state doesn't have a lot of influence, or I should say any influence over Medicare. Just a thought. All states cover it. And Medicare fee-for-service has been willing to submit data to each of the states that has requested in generally pretty detailed specifications, and that's helpful. Any thoughts here on this?
I wanted to ask, yes, on the administrative side of fee-for-service Medicare, are we going to capture the administrative part of that as well? Or are we just gonna capture the medical expenses?
So, no state has yet tried to figure out how to capture the administrative side of
Yeah,
Medicare.
it's
And
tricky.
the questions I would have is how would Medicare do that and break it down specifically for Oregon, probably on some sort of per capita basis. But no one has had, to my knowledge, an extensive conversation with Medicare about how to capture that and how to measure it.
On just the fee-for-service side, or just?
On just fee-for-service, on managed care, it's included.
Well, right,
as we talked
exactly.
about.
So we're gonna have a database that will have the medical costs for all 15% of our population, but we're only gonna have the administrative costs for about half. Oregon has a lot of Medicare Advantage. I think half the state is close to being enrolled in it. So I don't know if that presents an issue. I just wanted to raise it.
So thinking about it from a reporting perspective, so this is going back to our conversation about the net cost of private health insurance. In Massachusetts is the only example that has the ability to report at this point. They're reporting the net cost of private health insurance at the individual insurer level. They're not reporting it it's in aggregate at the market level, meaning Medicare, Medicaid, commercial.
Correct.
And then it's included in the total.
Okay.
But it's not broken down between Medicaid fee-for-service and Medicaid
Okay,
Advantage.
all right, okay, good.
So it's a known issue.
Got it.
Just want to mention something more about the fee-for-service. When I think about Medicare, I think about it more in terms of 3 buckets. So there's the traditional Medicare fee-for-service. It's direct between people and the government. But then there's Medicare supplement, which I assume is fee-for-service. Is that what you would count as fee-for-service?
Yeah.
Because it's not Medicare Advantage, right?
Right.
So I think you can capture what the carriers do for Medicare supplement from administration and also under cost sharing.
Yes, that's true. That's right. Yes.
Okay,
And this
good
also
point.
gets,
Yeah.
if we're gonna get at the super detailed level, it also gets a little bit complicated, but is doable when you're talking about a standalone Part D benefit. And there just needs to be specific instructions on where to include that and how to capture that data. So you're not double counting data.
Right, okay, good. Other comments on this? Okay.
Okay, so then there's Medicaid, there's fee-for-service and the spending that's happening through the CCOs. And I don't see why you wouldn't include that. Anyone disagree? Okay, moving on. Then we have dual eligibles. These are individuals who have both Medicare and Medicaid coverage. You just have to be careful in your specifications and how you define this so you don't double count and you have the right insurer reporting the right level of data. But otherwise, it's completely doable. Okay. Okay, then we have the commercial population. This is, the largest covered population in the state. I will say one of the potential con is that you do need some insurer cooperation here. In the other 3 states, we'll talk a little bit about data and we'll go into this in much more detail later, the insurers are reporting into the state. Because the insurers have the most up-to-date data, they also have some data that may not be reported elsewhere.
And this includes both self-insured and fully
It
insured?
includes both self-insured and fully insured.
Do they, in Massachusetts, do they draw a line in terms of membership size? Or is it any insurer offering coverage for any individual state?
So, that's a good question. I'm not sure if Massachusetts has a specific membership. Actually, Massachusetts does have a specific membership size. And it's pretty small. In the other 2 states, because they're also very tiny states, they're doing basically the top 3 or 4 insurers. And so that would be a specification question of which particular insurers you would want to report into this. But I would assume you'd want to capture the vast majority.
Question that might be too weedy. If I am self-insured and I have a TPA who is not based in Oregon, how does the reporting work to capture? that?
So I think that's
Or
goes
is
to
that the
Jeremy's
same?
question.
Okay.
No, it's not the same question, but it sort of goes along the same lines. So, if the insured if it's a TPA out of state, it's up to the state to decide whether or not they want to request the data. And then I don't want to go into the issues about whether they can have the jurisdiction to request the data. That's not in my bailiwick at the moment. But I will say that in at least Rhode Island and Delaware, that data is not captured.
Do states, through the insurance commission, even have awareness of that? If the TPA doesn't offer a commercial book of business that's fully insured?
I'm not sure.
Yeah, I don't think we have
know.
good data on out-of-state TPAs.
Andrew's on the phone, he might be able to answer that.
No, we do not, no.
So it would be hard even to find them, which might be why other states don't try to.
Right. And I don't know to what extent how large of an issue that is here in the state.
It's
And
about 7% of all self-funded employers are within outside or with the TPA.
7% of self-funded are within an outside TPA.
And they're typically outside of the state.
Okay.
Say that again?
It's a very small number of employers are actually with the TPA that are outside of the state. It's, the last time I looked, it's been a while, so they don't typically move too often now, but it's about 7%.
What's the data source for that? You know that it's 7%?
5,500 homes. Which are also themselves dated, so just keep that in mind. If it fluctuates up a point or two or down, it's not a large population, is my point.
Angela, do you mind if I just clarify? So that's 7% of employers.
Speak up a little, Craig.
Was that 7% of employers or employees?
No employers, you're right.
Yeah, so typically it's larger employers, so this could be large as a percentage of the population.
But they're used to reporting on data, so if you wanted to capture it, it would just have to be something we have to focus on if you wanted to gather that data. They're used to reporting it, so.
And does that include Taft-Hartley's, Angela? So Taft-Hartley Trust usually use TPAs.
No, I don't know the answer to that.
And what did Massachusetts do around Taft-Hartley's?
I don't know the specific question, but we can get back to you.
Okay.
Question for the commercial in the individual space. It's more of a trying to problem solve this. What do we say about reinsurance? This sort of
Jenny, is your microphone on?
Yeah, just before.
Just get it, yeah, we can't hear you.
So in the individual space, you have a pretty extensive lag around the risk adjustments and settling into the different years compared to the incurred years. We just look at the cost. So we kind of default into any risk adjustment really becoming a premium equation conversation. So do we report this at all in the other different buckets?
I'm not sure I understand what you're saying. Are you saying individuals,
You look at
those
the-
in the individual market?
The individual segment, the
Yeah.
exchange.
Yeah.
It had come with both a reinsurance and a risk adjustment mechanism, which one is more frequent, the other was lagged for 6 months. So you can get a large swing either way in the subsequent year compared to the year with reporting whatever you want to report. Because that's not really a cost, think about it as an insurance mechanism. So this is completely just carving out from this context, or not.
So in the other states, I don't think that's necessarily considered. I mean, the timing in which the data are collected is considered. And there is a relative significant lag between when data are collected. It's done on a calendar year basis, but it's not until September, October, or November that the data can actually be captured. So for the prior year. So if by that point, some of these challenges can be ironed out, or the data can come in, and a better understanding of that.
And I'm saying the data don't come in at all, it's just complete a carve out, because it is not a cost-based equation.
In the individual market.
Yes.
Yeah.
It's more of a clarity question, right? If it's not to cap the total spend on the cost of a claim base, these other mechanism is
That shows up in the margin though, right?
Yeah.
So I mean, it's a lag, but
Exactly,
yeah.
just the cost.
I believe Massachusetts does a preliminary and then a final, right? They do a.
They do.
So there's some ability to go back for things that are coming in not on the calendar year.
Right, and that was a function of the statute mandating that they get reporting earlier than they really needed to, or could. Okay, so, I don't think there's a question here about whether or not we'd include commercial insurance, right?
And for those keeping score at home, at this point, you have 92% of the lives.
I'm sorry, say that again?
At this point, you have 92% of the lives based on the cumulative percentages of who's covered now.
Yeah.
Thanks for keeping track. Okay, so then, a couple of other tricky populations. One is the Veterans Health Administration. This is spending at the VA, and that would include, but not that would exclude individuals with TRICARE who are not receiving their care at a VA facility.
It would exclude.
It would exclude them because TRICARE is the insurer, and if this, so the real issue is this was a data issue in the other states. So the VA publishes data. No state has asked TRICARE for data. So the difference here is that the VA is reporting data at the state level of what they're spending within their state bounds, within each of the state bounds, and TRICARE is sort of akin to an insurer. And TRICARE could report any individual covered individual's care at any facility within Oregon, whether it be at a private hospital or at a VA hospital, for example.
But we're saying TRICARE would be included and asked to report.
TRICARE is a separate
Not yet.
category that will ask. Yes.
Okay.
Well, we can talk about them together.
Sure.
And probably we should talk about them together. So the other states have, actually I shouldn't say the other, Rhode Island and Delaware are pulling data from the Veterans Affairs public data that they have available on a website that states how much spending has happened in those two particular states. None of the other three states have requested data from TRICARE. You wouldn't want to do both, let me say that. You would not want to do both, I'm sorry.
So the VA data includes what TRICARE paid?
To the VA. Yes.
Okay. What about if?
So
What if
TRICARE would be
TRICARE
more
pays?
comprehensive.
Okay.
TRICARE would be more comprehensive because it would include any of the spending at the VA or outside of the VA. The question is, can you obtain that data in such a way that that could benefit this program? I don't think a state has yet figured that out. And so if that's the angle that this group wants to take, I think we could do some more research to figure out if TRICARE would be willing to submit data to this effort.
I also don't think the other states have really pushed on this, to be honest.
No, I will also say, if we go, it's a tiny population. It's a small population.
Yeah.
I had a question about the VA, so you said 1% of Oregonians receive their care this way, but it could be folks that have other care elsewhere too, right? You could have somebody who has Medicare, but is choosing to receive some services at the VA, so it really could encompass more than a 1% slice of the total population.
Yes, you're correct, but I believe in the way the data are captured, by the way the data are reported in the other two states, it excludes that, but
Okay.
can we make a note to look at that?
Yeah, so that just seems really low, that only 1% of Oregonians are veterans and then receiving care there. And it doesn't sound like the data is hard to get if we did decide to include that into our data set, right? Specifically for
It is
VA expenditures.
not hard to obtain, it is not clean though, I will say.
Okay.
It's a lump sum. You cannot get it down into the detail that would likely be requested from other insurers or from what Medicare is reporting.
Okay.
It is one lump sum,
That's it.
that's it. But again, further outreach to the VA or TRICARE has not been done, and should that be of interest, should that be a population that you want to include, that certainly can be done. And we can come back at a future meeting and say, it's doable, it's not doable.
Just for my education, what type of entity is TRICARE?
TRICARE is a government payer.
So it's, I mean,
It's health insurance for the military.
Right,
It's the
right, but
military version of
it's just,
FEHB.
I mean, okay, so it's just federal, it's a federal entity, so.
And it contracts with private health insurers to administer the
Right.
benefit.
Right, okay. I mean, so if they contract with private health insurers to administer the benefit, do the private health insurers not have the data that would be reported?
They would have
Okay.
claims that they paid out. I don't know who the carriers are for TRICARE in Oregon, but.
Okay,
we-
so
we-
it's not as, it might be not as much about getting the data from TRICARE as it is ensuring that we understand the private insurers that administer TRICARE and that they report the data?
There is a good chance, I would assume, that they will go back to their federal partners and ask them, is it okay if we report this data? We've had this issue just come up with federal health benefits. They've stopped reporting to state all-payer claims databases. So I think there's been some shift at the federal level. So could be possible that even if the insurers are okay, the federal government's not.
It seems though, since federal government administers Medicare and they're providing the data that.
Two different agencies.
That's a big federal government.
So would you like us to do more research to figure out if these data are obtainable or not?
I think we should just ask. Let's see what happens. Why not ask, since nobody else has really asked?
Okay, we'll do that. Okay, so then we don't need to talk about TRICARE, but FEHBP. I didn't know FEHBP stopped reporting to all payer claims databases, but in the other states, FEHBP is being reported in aggregate with the commercial insurers that are administering the benefit.
I think on the issue with this TRICARE and the FEHBP, I feel like the issue is going to be a huge segment of our population in the east of our state. And so, I think that's going to be where the rub is, and so I feel like it's worth actually digging in here, maybe more than some other states like Massachusetts and Rhode Island, because it will be a bigger swath of our rural population.
Okay, we can dig in and do a little bit of research and come back at a future meeting with some more information. Okay, all right, so then we have the correctional healthcare system. So this is state and or county spending that is caring for individuals who are incarcerated, unless they are an inpatient at a hospital, at which point Medicaid covers it, and that will be captured under Medicaid. But there are plenty of other healthcare services that happen outside of that.
Sometimes that might be true.
Okay, when it is true.
Yeah.
When it is true, yes. Yes, actually, in certain circumstances. So one of the challenges here, if there's state and county spending, it may be challenging to capture all of the data. I will also say that I'm not sure that this would be a specific line item that you would want to look at. It would probably, I think it's fair to say that this is probably underfunded. And so, assessing it against a growth target may not be as intuitive, but including it in a total expenditure sort of lens would be inclusive.
I feel like this is a big rub for me on the state healthcare expenditure side. I'm not sure about on the cost growth, setting a cost growth target based on this information, but I feel like on the expenditure side for the state, and the fact that every other place where we have set a cost growth target, we have done that in all of our other state plans with the exception of corrections, and continue to let corrections operate outside of a system that I think is a little bit unaccountable when it comes to their not only healthcare spending, but their healthcare outcomes. And unfortunately, we have had a justice system that has disproportionately impacted people of color in our state, and it's causing a whole swath of issues for the incarcerated population. And so I would say we should include them because they need their cost growth target, or exclude them and figure out some other state way to put the cap on them and deal with them through issues around the health policy board, around quality care and other issues. But the corrections absolutely does need to be dealt with in some way, so.
some of what you're saying, I think, could fit into the cost growth target. Some of it, I think, is a little bit out of scope
Yeah.
for this particular group. And so I wonder if when we come back to the data strategy questions, we can think about how to look at the data in particular for corrections, as opposed to, some of this isn't gonna be addressed, sorry, by
Yeah, I agree.
incorporating them into the total. Because I'm also thinking that knowing how the data are collected, that this is gonna be a lump sum figure.
I think this is I don't feel like it's a question for us. Maybe it's not a question for us at this group. It's more of a question for OHA about how they want to address and deal with corrections. And so either coming back with a proposal, yes, we should include them based on our information as the health authority, or no, we should exclude them and we're gonna do these other things. That's where I would see the decision-making point.
Yeah, I think we have not spent a lot of time on corrections as an agency, in part because they're a separate agency.
Yeah.
I think it'd be more about trying to get a flavor for this group. Do you want us to try to go down the road or not? We can certainly spend a little bit of time offline trying to understand more of the corrections piece. The county piece is going to be even harder, I think. So I think we're just trying to get sort of a temperature check. Well, we can certainly do some work offline and figure out, a little more detail on the corrections spending and bring it back, or have it be a separate conversation.
I think, what might help here too is to understand how big are those dollars in comparison, because we're looking at population, we're looking at the number of people served, we're not looking at how expensive it is to serve them. And so we may look at this and go, oh, it's only 0.5%, but it might turn out to be a much bigger total dollar amount, and so that is important. So I think maybe before we decide fully, we should kind of look at how big of a chunk of dollars that is.
And it is disproportionately large. Again, the county piece is hard, but from the state perspective, you're looking at about $150 million a year. And a lot of that has to do, it's disproportionately large because of the demographic mix of our inmates. In particular, somewhat surprisingly, inmates have a longer life expectancy than us folks on the outside. And so, and given that in Oregon that we require that longer, they don't get in car wrecks and things like that, and so, given in Oregon that we require that we provide the community level of care to our inmates, this is a really rapidly growing and disproportionately large population. But that said, I'm not sure it moves differently than the overall health spend.
That's funny, being in a $20 billion agency, I was going to say $150 million doesn't seem like that much, but it's a different perspective.
That's right.
Okay.
Okay. So then the last population to consider is those receiving care through IH&S. I will say I did speak with CMS about this, and getting data on Indian Health Service spending is a little tricky. I should say a little bit more than just tricky, because of the funding streams and the different mechanisms, and we'd have to be very careful about not double counting, in particular for individuals who are also eligible or receive Medicaid benefits. There would also likely have to be some work with tribes to seek permission to receive their data as well. So there's further conversation that can be had to understand this more, or potentially not. Now, I will say this doesn't mean that we are excluding Native Americans from their cost growth. If they have private insurance, Medicare, Medicaid, that's all included. It's just the specific Indian Health Service spending, and that's not all health services. It's lump sum payments that go to clinics that can be used for a variety of things. So it gets a little bit messy.
This question related to expenditures for Oregon State Hospital for psychiatric patients. Which bucket would that be reported under?
That's a good question.
It's not on one of these lists. It's something that we would have to add as a separate category if we wanted to.
So we probably should do
that.
that.
It's within OHA. It's easy for us to pull the numbers. The thing that will be a challenge is it's not necessarily an annual figure of cost for those individuals. They're cycling in and out of the hospital, sometimes for short periods of time, sometimes for long periods of time. So it'll be it's data we can include. It's in our budget. It's not necessarily going to be analogous potentially to an annual per capita spend like in southern markets.
So it's in Rhode Island and Delaware, their state hospitals are, I should say Rhode Island, I don't know specifically with Delaware, it's rolled up into the Medicaid bucket and Medicaid spending there. Okay. Did we miss any sources of coverage? Other than the state hospital one?
What, I didn't hear their feedback of Indian Health Service.
Oh, thank you.
Do you have a sense of what portion of the total care provided to those populations is IHS versus going through Medicaid or other?
I don't know. No.
So will the Native American clinics be included in, say, our Medicaid data? And so would it be captured there?
If Medicaid is paying those clinics Medicaid dollars, yes. But that's only a portion of the funding.
And does anybody have an idea of what percentage of this?
From a spending, I don't.
From the number of tribal members that are in Medicaid, I want to say it's about 25 to 30,000. So it's out of 1 million, so it's a very small population. But to Megan's point, the funding stream when it comes to tribes and Indian services is unbelievably complicated, and it's varies by tribe as well, depending on treaty arrangements.
And many tribes have their own plan that they've structured, so several of them actually are self-funded, believe it or not.
So those would then be reported if they're self-funded.
Those we could report on, right? Because they're already be part of the general commercial, I think, type of business. But I don't know what percentage of that 2% actually has private coverage versus the Native American.
Can we just ask our tribes?
If they would like to be included.
Yeah.
Yeah, we can. We would need to go through a tribal consultation. Okay, we certainly could not collect the data without agreement from the tribes. It's a government-to-government relationship, so we would need to go through this conversation.
So I say we should ask our tribes just like we were going to ask the federal government around TRICARE.
Okay.
Okay, so just abundance of clarification, so OEB, PEB, they fall under commercial. Taft-Hartley was under commercial, that's what you brought up before, but we're trying to figure out
It's unclear.
how to measure it. It's unclear how to measure it, or it's unclear that it would fall under commercial?
It falls under commercial. It's unclear how it gets included in the reporting.
Okay, and then private self-insurance falls under commercial. For private and for Taft, OEB and PEB I think are easier because we have all their information. The question on in-state TPA versus out-of-state TPA, is the concern measuring the SG&A and profit, or is it being able to get all of the information?
All of the information.
So the concern is for TPAs, out-of-state TPAs of private insurance, potentially businesses that target old, we would not have visibility into the spending.
That's possible. Yes, that's very possible.
And that's how it's handled in the other states.
The other states are, in Delaware and Rhode Island, there's a small number, because there's a small number, of insurers who are regulated by their insurance agency, who report into the data, into the cost of targets. So if they're completely outside of the state's not collecting data from them. Now that doesn't, if they're operating completely out of the state. So for example, United Health Group offers commercial insurance in both Delaware and Rhode Island. They are reporting into Delaware and Rhode Island. But obviously, if a employer is receiving health benefits from or TPA from a plan completely outside of the state, and they have no other state business, that data doesn't come in.
So let's be clear on this. I think the vast majority of people that we're talking about are folks that probably work for large national employers like, say, Home Depot. I don't know who does the health benefits administration, or let's say it's United. So are we suggesting that in the case of United, which does sell private plans, fully insured plans here, they have Medicare Advantage here, but in the case of United, would all of those Home Depot lives that are spending tons of generating lots of claims here, would they, Megan, not be possibly included in the denominator?
So in the other states, because they are residents of the state, they
Yes.
are included.
And we can get the data from United's TPA?
Yes.
The issue, Jack, would be TPAs that do not have a big market present within the state, but are doing business for a self-insured employer.
Okay, I got it.
Thank you. So for example, I don't know if Humana's here, they tend to be regional. If they're not, but if they had a large self-funded account, then we wouldn't know about it.
I see, okay. Well, Humana might be a good example of that, actually. I don't think they have a big commercial presence here, but they probably do some administration for some self-funded employers that have employees here. I don't know, okay.
Is there an existing mechanism where that could be leveraged to require an employer who has a self-funded plan to require their TPA to report?
No, there's, Jeremy, go ahead.
Well, I think when you start to get into requiring employers specifically to do stuff, you really start to run afoul of ERISA. I think the reason Massachusetts has not run afoul of ERISA is it's been at the TPA insurer level, and it's been at an aggregate level. They aren't reporting by line of employee group or employer group. They're asking for aggregate numbers across all of the self-insured business that the TPA operates.
Okay.
So I was wondering if there's a need for a bucket for other non-federal matched healthcare spending that OHA pays, like COWM and for Cover All Kids?
I don't know the term COWM.
Yeah, I would consider, we were using the term Medicaid here. I would probably call that more broadly Oregon Health Plan and sort of all of the different eligibility programs that we have, some which are actually outside of Medicaid funding, but are a Medicaid level program.
So what I'd like to do is just do a quick recap of the populations that we know are going to be included, and then the populations where we're going to try to get a little bit more information before we make a decision. Can you take us through that, Megan?
Yep, sure. So Medicare, Medicaid, which, as Jeremy just mentioned, let me go to the slide to show you this. So Medicare and Medicaid, which largely Medicaid is also going to be including other state CHIP, for example, and other state-funded programs and eligibility categories. Commercial, fully and self-insured, unless, and it is an operational level detail that needs to be worked out later, probably by OHA, about which particular insurers may be reporting in at what level of membership. But they'll be included. We're going to ask TRICARE if they would report, and if they do, then you would eliminate VHA, because you would duplicate that. If they don't, we'll have to have the conversation about VHA. Correctional health system we're going to ask, and we're going to ask the tribal council.
Tribes, yeah.
About their willingness to share data.
And I'll just say that the tribal piece, don't expect a near-term solution decision on that. That's a longer conversation that we'll need to walk through.
Okay.
Sorry, one more question for inclusion. Is that already embedded currently about like FQHCs or community clinic serving population is uninsured?
So, no, we talked about this a little bit earlier. The uninsured, it's difficult to capture that data, and, okay, great. Okay, we're not done with this conversation though. So, when we think about all of this, there's two questions that we have to ask. What should be the residence of the individual, and what should be the location of the provider? So, there's some complications here because we have Oregon residents who see Oregon providers. I think that's kind of a no-brainer. We want to capture that. There are going to be some Oregon residents who are seeking care from out-of-state providers who would naturally be captured as part of a commercial or Medicare, for example, insurance. So they may have wintered in, because you guys don't winter in Florida.
Some do.
Arizona, thank you. Wintering in Arizona, they may have unfortunately gotten in a car wreck in Washington, or New York, or maybe they're on the border and they want to get care in Washington. So we have to talk about that. We'll walk through each of these specifically. And then there are going to be some folks who show up to Oregon providers who are from out of state. They may be border states, or they may be from, they may be Michael and I. And so we have to ask ourselves about whether we want to include those particular individuals. And I think it's clear we don't want to include out-of-state residents and out-of-state providers. So let's walk through these one at a time. I think, as I mentioned, it's clear we want the Oregon residents and the Oregon providers. Do we want to include Oregon residents who receive care from out-of-state providers? So these, again, may be individuals who routinely receive care from out-of-state providers. They may have received care on a one-off basis. And it may be that you have some health systems who have affiliated or employed physicians who are in border states. And so I will share that the 3 other states are capturing data for the spending of any individual who resides within their state, regardless of where they got their care. Part of the reason is, I'll just explain the reason. Part of the reason is it would take a lot of effort for an insurer to report a particular resident's claims and separate out any claims that happened in a different state.
Right.
That's good. Yeah, I was just going to ask if the cost of care, the total cost of care, when you're looking at out-of-state providers going up faster than what we put in as a target, it doesn't sound like there would be any mechanism, I guess, to control that.
No.
So it's more just informational, it's kind of interesting, but it shouldn't play into our total cost of care.
Well, and I'm not even sure, at least thinking about how the data would be collected, it would be a lot of effort for an insurer to say, this population received care in these states and this population received care in Oregon, and separate out on a claim line by line level basis.
So how do you handle like a state employee who earned their benefits while employed in the state of Oregon, but they're now residing outside of Oregon but getting their benefits through Oregon?
So that is a perspective that we offer in a couple of slides to talk specifically about that. But if they are an Oregon state employee and reside outside of Oregon, then their benefits would be captured, their spending would be captured under the idea of you're capturing the spending by basically their payer for wherever they go. And I think we know the percentage of how many people that is.
Yeah. Well, percentage of care, too.
So there's about 2 to 4% of PEB and OEB subscribers who live out of state.
Because they live in Vancouver or on the border towns, Boise, on that Ontario border, Vancouver, but they work in the state.
Well,
Oh,
and
so
there's
they
some-
live on a lot of them live on the border. So they live in Vancouver and then commute into Portland, because of affordability issues, or live in Idaho and then commute.
And there are a handful of retarees.
Yeah,
but
and
it's
a super
pretty
small number,
numbers.
super small number of retirees, but most of them are commuters.
So how would they fit?
So it depends. If you want to include out-of-state Oregon residents who, I'm sorry, we're talking about, sorry, we're in the other box. And that's where I got confused. So.
We're not there yet, George.
Yeah, sorry.
So again, it seems very hard for me to imagine that we would not include Oregon residents who get care out of state, because many Oregon residents travel, and every now and then they are going to have an episode, and it's going to be captured in the claim. And the only reason you wouldn't do that is if we saw wild swings in the amount of care that Oregon residents are getting outside of the state, but I can't imagine that's the case. So as one person on the commission, I'm hard pressed to understand why we would not include them. But
I'm in agreement with you, Jack.
yeah,
Okay, great, then we'll move on.
let's move on.
Okay, so out-of-state residents who receive care by Oregon providers, a little bit different than those who are covered by Oregon or covered by as a state employee. But the idea here is these are individuals who are in the border states or anywhere else who receive care by Oregon providers. The challenge here is if they're not covered by someone who, or covered by an insurer who's reporting in, and I will say Medicare is only reporting in on residents thus far, you're going to be challenged to capture this kind of data. Yes, okay. I'm moving quickly because I hear we're a little bit tight on time. So just to provide the perspective, this is what the Massachusetts, Delaware, and Rhode Island are doing. Any individual who is an Oregon, who is a state resident, regardless of where they receive care. But there are the challenges of the two different perspectives, from the insurer perspective and from the employer perspective. So from the insurer perspective, they are going to cover, likely, individuals who don't live in the state. And from the employer perspective, they are going to pay for employees who don't live in the state. And so this can be somewhat of a challenge. In Rhode Island and Delaware, where the employer site is what matters. So it's a slight nuance to the resident. So where the employer's headquarters are is what matters in those states.
So I'm maybe lost a little bit in this, because I feel like if you go back a slide, so if you are an out-of-state resident and you see an Oregon provider and your insurer is an Oregon insurer, your data would be collected. So to Jordan's point, so PEB data, that we would report on all PEB data, correct? So Providence would report on all PEB data, regardless whether you lived in Vancouver or not, regardless whether you got your care at Salmon Creek or at Good Sam. They would report that data.
It depends on how you want to design the program.
So, so I get that that's the question, but for Providence to say to them, I want you to then slice your data for PEB and exclude anyone in PEB who lives in Vancouver but got their care at Sam, like that seems absurd to me. Like,
so the nuance is the state of that in the states that are operationalizing this, the nuance is that the state employees are all reported regardless of where they live.
So, but then if I, like our own healthcare, like our union's healthcare. So we have 2 staff people who live in Vancouver. We have Kaiser Health Insurance, do the commercial insurance. So then is Kaiser going to exclude their care when they go to the interstate clinic because that's closer to our office?
They're doing that in the other 3 states because they're residents.
Then they go to the Vancouver options.
It's all depending on the rules, how the rules say.
And so is it worth splitting it at that level
It's not being split at that level. In the other 3 states, they're saying if your residence is, if the state primary address is in that state.
Then so for my group, they would just exclude those 2 people and just report on the data for the rest of the group.
Correct. But that is not what's happening under state employees in the other 3 states. That's what I'm trying to.
I see. So state employees are separate in the commercial pool because you just report across the line. And then, but all of the rest of the commercial pools would be divided up along those lines.
That's my understanding, yes.
I feel like that's a lot of people in Oregon, and it's a lot of like, yeah, that's a lot of people. It seems like to me, when you look at the 2 borders, when you look at that Vancouver border, because I don't want to be disrespectful to people who live in Vancouver, but it is a suburb of Portland.
So the other way to do this is by employer situs, to say where the employer has headquartered their operations is how commercial insurers report, regardless of where that individual lives. The challenge is for companies that
Like
are
Home Depot.
like Home Depot.
Or most of the companies that employ the vast majority of Oregonians are not headquartered in Oregon.
You could then, you could ask insurers, all depends on OHA's relationship with insurers, how many questions you ask them. But in theory, you could ask them to do employer status and residence, but that's getting into a lot of technical.
I think
So
if you
I
want
guess
it to
I'm
be
just-
accurate about capturing it, you have to do it by employer site, not by headquarters, because there are companies that are operating, that have large operations that are not actually headquartered in Oregon.
I think that would get very challenging from the insurer level.
I mean, but otherwise, there's really there's no way to
Yeah,
split that up.
I'm not sure insurers are able to slice that level of detail.
Yeah.
Because insurance isn't purchased that way.
Yeah, no, I realize that, but otherwise, you're gonna end up with data that is really wonky and you're not gonna
Well,
be-
so as Jack said, we can't let perfect be the enemy of
Yeah.
good.
So that's my question. What is the percentage of,
Out-of-state residents, Oregon.
I guess, expenditures or people in those first two buckets that we've got checks on? Do we know, Zachary, what that represents? Is that going to be 90+% of the activity that we're trying to measure?
Could be, hard to say.
Hard to say.
Yeah.
Yeah. Okay.
So, I
That's it.
guess I have a question, I just have a question about this third bucket. Like, what is the percentage in the third bucket in the two markets where that applies?
The
So-
out-of-state resident and Oregon provider?
Yeah, so in the southern Oregon area, the Portland area, and the Ontario, basically. So, I feel like that's, if it's less than 5%, maybe it is excluded and we call it.
I think your PEP and OEP data probably gives you an indication of that, right? And
Yeah.
it's tiny. It's
That's-
2-3%.
Yeah.
Which frankly is way below what some other states look like.
I'm not sure that PEB and OEB data actually do give you that accurate look because some of the jobs in those classifications, you're required to live in the state and be a resident of the state to be employed. So if I looked at our Taft-Hartley data and our janitors who are on those borders, I bet you we would have it would not be tiny, because it's a suburb, it's a commuter suburb.
The existential question here is,
Yeah.
what do you want the cost growth target to be? So
I
if this is
understand.
about state healthcare spending, is it spending for Oregonians? Or is it
That's right.
spending
Yeah.
for,
Washingtonians
services
too.
provided
Yeah.
by healthcare providers in Oregon? That's
the
the big question.
Right. Ken, you have a comment? Ken?
Yeah, I don't know if the question is, can you get to the data? Can you keep the cut of the data pretty straightforward so that you get consistent data across the board? And it seems to me that you focus on Oregon residents. That's an easy cut to do with the data that gives you what you need.
Yep. Other comments on that? I happen to agree with you on that, Ken. Do other people have perspective on this?
I agree.
You agree with that? Yeah.
Okay.
Okay, so are we comfortable?
Deciding? Are we deciding?
Well, I think we're gonna, I think we
Right
need to
now?
make a decision. So,
Okay.
do you want to do a vote on this? Should we take an action on this?
But your charter says you make decisions by consensus, so I would see what the feel of the room is.
Yeah, okay, so, it sounds like, Felicia, you're having an issue with this?
Yeah, I'm not in consensus yet because I feel like I could get to consensus with more information. And so if you are at a level of urgency where we need to make a decision today, then I'm not in consensus.
Okay.
If we could make a decision at our next meeting on this, maybe I could get to consensus.
And your issue is that, does consensus mean everybody has to agree?
Yes.
Yeah. I thought it was just me. So, Zachary, let me ask you, do you feel that you could do some amount of research and come back to the group in January with a fairly accurate figure of how much we would be excluding from the analysis if we just stick with Oregon residents only?
Yeah, I think we could try to find some analogs
Okay.
that might be helpful. I'm
Yeah.
very concerned about PEBOM maybe not being the best analog,
Yeah.
so what other
Yeah,
data
yeah.
points can we
No,
string
that's fair.
together?
I think the other thing we could look at is what our all payroll claims database rules are, because we've worked through some of this already in terms of who's reporting for the all payroll.
And there's value of being consistent with that reporting.
That sounds great.
That sounds really
Value.
good, yeah.
Yeah.
Okay, so we've landed at a place that will work, yeah.
Yeah.
Okay. We need to move along, yeah. Okay,
Jeremy.
Jeremy,
I'm up next.
thank you both.
So I'll keep this pretty brief. We're running a little behind. We are, as I mentioned, we're trying to build out some other opportunities for getting input, and I'll give a couple examples of that. I'm presenting the Hospital Association board tomorrow, and have asked that they have some type of regular group that we can keep informed as we're going through this process and get some input from. I know OMA has made a similar offer and planning to meet with them a couple of times throughout this period. So we're trying to build out some opportunities for a broader group of stakeholders, consumer advocates as well. I think I just more wanted to let folks know that we're doing that, and we'll bring back probably not a super detailed plan, but a better kind of sketch of what we're thinking about at the January meeting. I think the big thing is if there's big activities folks want us to be doing that would help you in the meantime as you're deliberating on this, it would be helpful maybe just to get a couple of bits of information, or you can email me offline, and we can kind of feed that into our process between now and January as we're putting together that engagement plan.
One suggestion, and maybe it's only in Central Oregon, but the Central Oregon Health Council, who's the nonprofit who oversees the CCO, their board has an interest in this, so I wonder if that equivalent organization for each CCO might be one that you try to reach specifically.
Yeah, we're happy to, if you hear of organizations that want an update or a presentation at some point, we're happy to hit those folks up, but we'll, the CCOs that are not around this table have been on our mind as well.
Okay. Let's look toward our next topics and come to the schedule.
Yeah, I think we just want to, so in light of the conversations that Jeremy's going to be having, you may want to have conversations with your own stakeholders or colleagues. And so we just wanted to remind you that we have a lot of conversations that we're going to have over the next 8-9 months. And they're bucketed in here. We have the cost growth target, which we've been talking about and we'll continue to talk about. We have a charge to talk about quality and equity. We have a data use strategy, which will support the cost growth target and the quality and equity discussion. We'll be talking about transparency and accountability. And of course, the taking action bucket is how to support providers and other entities in lowering the healthcare cost growth. So we have a loose outline here of the conversation on a month-by-month basis. I will note that we have a sort of a very planned discussion. We will modify that as conversations perhaps bleed into others. So be mindful of that, and as you see, sort of as we get a little bit later, the detail is not as well defined because we still have to see sort of where we go. So you can keep that in mind when you're preparing for meetings or you want to have conversations with your own colleagues.
Megan, when are we trying to establish the growth target figure? Is that scheduled in
That's
January?
January.
It is.
Mm-hmm.
So we want a decision there. That's kind of a main.
Well, I'm not sure, so there's going to be a lot of information that's shared.
Yes.
And I will say when we talk about, so at our next meeting, we're going to be talking about the figure, the cost growth target.
Yeah.
We're going to be presenting a variety of different options. However, we are not going to be talking about a value to the target. We're not going to know if it's 2, 10, 20, that we're having a theoretical discussion. Based on that theoretical discussion, we'll do some calculations in between meetings and come back in February and then really talk about
establishing
the value.
The value.
Yes.
Okay.
So it's purposefully done that way because we want to talk about the theory behind this before we get into it.
Okay, and that's the substance of our January meeting, isn't it?
Yes.
The understanding.
Your heads may spin a little bit
Yes.
in January.
Yeah.
Just
Okay.
for forward.
All right. Are there any other comments for Michael or Megan on our process here? And of course, we will come back with some decision making on who's in, whether or not.
Yes, we'll have follow-up
We'll have
from this
follow-up on that.
meeting, for
Yeah,
sure.
perfect. Okay. So, Jeremy, do you want to take over on our public, I think on our public comment, we do have a couple of people that would like to make comments. Tom and Mary Lou Henrich. You're not married, I don't think, but you're two separate people. So why don't we come up, Tom, do you want to come up first? All I would say is we're trying to get as many people in. Well, we only have two, so come on up.
You got 11 minutes each.
Yeah, well, 2 minutes. It's capped at 2 minutes.
Again, thank you for having me here. Tom Simsick, President of Healthcare for All Oregon, retired family nurse practitioner. My comments as an observer through this whole process vary, but a missing piece, and I mentioned it last time, was the idea of there's a mission, but there's not really a principle behind this. And I asked before, and I'm hoping it'll sometime come up, that recognizing that healthcare is a human need, and then ask the question, is healthcare a human right? Is that the view of the people sitting around this table? Because I think that's an important thing to sort of ground people in the important work that you're trying to do here. One in particular thing, the issue of cost versus expenditures comes up, and the issue of cost is more, I think, broader, because people are feeling cost in lives, cost in things, where expenditures more means dollars to me, and I think focusing on that word would be helpful. I do have a question, I don't know if I can get it answered, because particularly one slide talked about TRICARE and services received at TRICARE. Does that mean TRICARE is paying for an expense? Because I know a lot of people that where they go to, families go to public services, and TRICARE may not be paying or reimbursing them for those public services in that. And so just finishing up, I want to bring up a comment from an employer in Oregon, in Corvallis. His name is Ron Lowe. He's from Woodcastle Furniture. And I'm going to read a portion of Ron's editorial here. Like many business owners in Oregon, I want to do the right for my employees. But when I offered raises, people had questions about it. And this goes back to cost to the state, right? Because we know that people then move out of the Oregon Health Plan at that point, a number of people versus when they get the raise. In a perfect world, I would offer employer-based health insurance. In fact, I did so for 23 years with premiums, but until premiums went up 47% for him in 1 year. But my mid-sized business is too small for an economic insurance plan and much too small for self-insurance. Health insurance would cost me far more to premiums than I can offer in increased pay. And an insurance policy for my employees might receive would have narrow networks, thousands of dollars in deductibles, and massive copays for medications. It could not match the simplicity and efficiency of the Oregon Health Plan.
Hey Tom, we're over the time. So.
Okay, and I just want to comment maybe at the end, which is I really appreciate the commentary that people were trying to bring in of all the other items that aren't included are being captured, and I'm hoping that you continue to focus on that list that was mentioned, and I won't add any more to that list at this point. Thank you.
Okay, thank you, Tom. Mary Lou Henrich. Good to see you.
Hello there. I'm Mary Lou Henrich, and I'm retired, did a lot of health and public health and you name it stuff for a long time in Oregon. And I think this is great to be really kind of looking at the costs, because I think I'm on the board of Healthcare for All Oregon, so as with Tom, we're trying to look at a way to change things and get everybody under the tent and all of that. But that's not what I'm going to say today. I'm going to say that even if we do that the healthcare system, all the pieces, I believe, are severely broken and are costing way too much money. And everybody's going like this. It's not me, it's over here. It's not here, it's over there. And there are days when I think, geez, is this really what I want to spend my retirement doing? Kind of tracking this kind of stuff, trying to figure out how to make it better. I don't know. But for the moment, that's what I'm doing. But I had a book that was given to me the other day, and I read it. It's called The Price We Pay. And I just wanted to encourage folks to maybe find it and read it. It's by a physician from Johns Hopkins who has really delved into a lot of the providers and parts of the system. And as you talked about the rebates on the pharmacy parts, read the chapter on a pharmacy benefits manager. It really will curl your hair if it's straight, or straighten it if it's curly. But there's a whole bunch of parts in here, and it isn't any one part that is doing the terrible bad things. It's all of the components are inflating costs, shifting costs, saying we don't pay for this, we don't do that. And you know, I think this is good effort, but it will be voluntary. And you know, I think with the Oregon Health Plan, you can kind of set a thing that we're going to say this is it. I think it's going to be difficult to really implement whatever you come up with, but it's good discussion. I think you've got good and people around the table, and that's all.
What is the title of the book again, please, Mary?
The Price We Pay.
The Price We Pay.
By Marty McCary, MD. Okay, and Don Berwick is a strong supporter on the back. There's a whole list of folks that you recognize. So anyway.
Thank you for your comments.
Thanks.
Okay, Jeremy, do we have anything around next steps that we have to remind people of?
I don't think so. Looking at Megan and Michael, I think we've got our couple of to-dos on both what's in and out of total healthcare expenditures, as well as running down some data on those other markets and programs. Anything else?
Yeah, I think I would just mention that on our slide, we have the 4 indicators that we plan on discussing. And so if you want to think about those over the new year, we're going to be talking about the potential gross state product, personal income growth, wage growth, and inflation as potentials. That does not preclude you from suggesting others, so please come prepared to do so if you'd like.
Well, I go further. If you have a favorite economic index that you hold close to your heart and you'd like us to consider it, please let us know in advance so that we can adequately prepare for the discussion.
Art will be leaning on you at that meeting. Okay, well, I want to thank both of you guys for your great effort, and to all the staff at OHA for making this process work just wonderfully. And to all of our fellow committee members, happy holidays, happy new year, be healthy and safe, and we will see you in January.